Everybody, we're going through this issue of JAVMA here from February 2015. We are going to be talking about this study, the initial experience with endoscopic retrograde cholangiography and endoscopic retrograde biliary stenting for treatment of extrahepatic biliary duct obstruction in dogs. This study comes out of the Animal Medical Center in New York City, as well as the Memorial Sloan Kettering Cancer Center in New York City, and a specialty hospital in Pennsylvania, as well as a research facility in the University of Pennsylvania. All right. It's got a lot of abbreviations, so again, bear with me. Objective is to describe techniques for endoscopic retrograde cholangiography and endoscopic retrograde biliary stenting for the common bile duct for minimally invasive treatment of extrahepatic bile duct obstruction in dogs. It's an experimental study and clinical report, 7 healthy dogs, research dogs, and 2 actual patients. The procedures: while the dogs were under general anesthesia, the pylorus was cannulated with a side view duodenoscope, and the duodenum was entered. The major duodenal papilla and minor duodenal papilla were identified. The major was cannulated. Endoscopic retrograde cholangiography and endoscopic retrograde biliary stenting were attempted with the aid of scoping and fluoro. Results showed that endoscopic retrograde cholangiography was successfully performed in 5 out of 7 research dogs and 50% of the patients, which is 1 out of 2. Biliary stenting was achieved in 4 out of 7 research dogs, 1 out of 2 actual patients, with either a polyurethane, which is 4 animals, or a self-expanding metallic stent, which is 1 animal. Stent patency was documented by contrast cholangiography and visualizing biliary drainage in the duodenum intraoperatively. No major complications. Follow-up 685 days after stent placement in the 1 dog provided evidence of biliary patency on repeated ultrasound and no evidence of complications. Conclusions were, this is a technically challenging procedure. So before we go any further, I want to show the anatomy here of, this is dogs. Cats are a little bit different, but pancreas here, pylorus of the stomach, cranial flexure of duodenum, descending duodenum, and then there's the major duodenal papilla, which has an interaction with the pancreatic duct as well as the cystic duct or common bile duct of the gallbladder. So that's the anatomy we're talking about with this study. Then you can see here the minor duodenal papilla down here, which has the accessory pancreatic duct that interacts with it. So there's a whole host of diseases here that dogs can get, and if it affects the drainage of the pancreas and or gallbladder, then of course you'll have a clinically ill dog. Okay, the introduction. Endoscopic retrograde cholangiopancreatography, first described in humans in 1970, is a minimally invasive technique, combines endoscopy and fluoroscopy to perform various treatments and evaluation, and localize gallstones to facilitate the removal. Bile duct obstructions can be definitively diagnosed and treated via therapeutic interventions, including sphincterotomy and retrograde endoscopic biliary stenting. In human patients, the endoscopic retrograde cholangiopancreatography is considered the optimal minimally invasive treatment modality for biliary and exocrine pancreatic tract disease in adults. The most common cause of biliary obstruction in human patients is stones, so cholelithiasis, followed by pancreatitis associated biliary strictures, pancreatic or biliary cancer, and common bile duct strictures. Endoscopic retrograde sphincterectomy with biliary stenting is considered the treatment of choice for many of these conditions. Traditional reported treatment for extrahepatic biliary duct obstruction in veterinary small animal patients involves a laparotomy with surgical manipulation of the common bile duct and pancreatic duct via choledochotomy, or a diversion procedure such as a cholecystoenterostomy or surgical stent placement across the major duodenal papilla. Surgical biliary diversion techniques in dogs and cats have been associated with a 25% to 73% and 50% to 75% mortality rate, respectively, which is high. When a traditional open surgical approach was used for the placement of biliary stents, The mortality rate has been reported 30.7% in dogs, 28% in cats. Prolonged anesthesia times, median of 3.5 hours, and manipulation of the pancreatic and biliary system in unstable patients may contribute to the high morbidity and mortality. In human patients, interventional radiology guided procedures include the placement of cholecystotomy tubes and percutaneous biliary stenting, along with interventional endoscopy techniques such as the endoscopic retrograde cholangiopancreatography and biliary stenting is an effort to minimize procedure-related complications. The use of cholecystostomy tubes or decompressive cholecystocentesis are other options for temporary biliary decompression, but these procedures do not allow drainage of bile salts into the gastrointestinal tract. Endotoxemia and bacterial translocation may occur because of the lack of luminal bile salts may promote increased intestinal permeability and intestinal bacterial overgrowth, which overwhelms the hepatic reticuloendothelial system. This typically requires enteric bile salt replacement of the drained bile via a feeding tube until patency is reestablished. These procedures often help stabilize the patient, which can facilitate a more definitive permanent decompressive procedure at a later time. In 2005, a study first reported successful diagnostic endoscopic retrograde cholangiography in 7 normal research dogs and 30 canine patients with vague gastrointestinal signs. Materials and methods. With the duodenoscope, the gastric lumen was entered, the pylorus was cannulated, and the duodenum was entered. The major and minor duodenal papilla were identified. The major one was cannulated with a sphincterotome catheter. A guide wire was advanced through the lumen of the sphincterotome catheter up the common bile duct with fluoroscopy. The iodinated contrast material was then injected through the catheter to identify the common bile duct. The guide wire was advanced into the cystic duct. A sphincterotomy was performed with monopolar cautery. A biliary stent was advanced into the common bile duct to traverse the major duodenal papilla. So all of that is shown here, A through H. H, you can see the blue tubing is the actual stent. A is pointing to the major duodenal papilla, B is them entering the papilla, and the rest is trying to figure out how to place a stent. And then here's another image here. This is the actual, that first picture was the research dog, this is the actual case. Results, research animals. They weighed a median of 18.6 kilograms, median age of 36 months. Pylorus was cannulated with a side view duodenoscope successfully in 6 out of 7 research dogs. The major duodenal papilla and minor papilla were identified in 5 out of 7 and 6 out of 7 dogs respectively. Endoscopic retrograde cholangiography was successful in 5 out of 7 dogs. Endoscopic retrograde pancreatography was successful in 5 out of 7. Biliary stenting successful in 4 out of 7. 5 French or 7 French polyurethane stent was placed in the research dogs. The time for the procedure was 90 minutes. And then in the clinical cases, case 1 was 11.5-year-old, 33 kilograms spayed female Weimaraner with signs of extrahepatic biliary duct obstruction. The procedure time from measuring from the time of endoscopy commencement to when it was finished was 24 minutes. An 18 French esophagostomy tube was placed prior to recovery in the event the patient recovered, developed clinical signs of pancreatitis, and enteral supplementation was needed. Case 2, 7-year-old female spayed mastiff, 59 kilograms, extrahepatic biliary duct obstruction. Discussion. Although surgically assisted choledochal stenting is not a new concept in vet med, it has only been reported as an adjunct to surgical biliary decompression requiring laparotomy, enterotomy, biliary, and pancreatic manipulation and prolonged surgical times. In a 2006 study reporting the use of surgically placed stents in 13 dogs, the median surgery time of 3.5 hours, mortality rate was 31 to 50%, and the outcome was dependent on the etiology of the obstruction. Once a common bile duct is catheterized, the need for a sphincterotomy at the major duodenal papilla prior to stent placement is controversial. In humans, this can be associated with a higher risk of complications ranging from 2% to 20%, hemorrhage, perforation of the duodenal common bile duct wall, pancreatitis, reflux of GI contents into the common bile duct. The benefits of sphincterotomy include easier stenting, cannulation, and the ability to remove large cololiths and opening of the ampulla where stenosis is present. Pancreatitis is the most common complication of endoscopic retrograde cholangiopancreatography in human patients, ranging from 1% to 20%. A study evaluating pancreatic enzyme activity after the endoscopic retrograde pancreatography, not the endoscopic retrograde cholangiography, in clinically normal dogs found no clinical signs of pancreatitis and no complications. In that study, there was a transient increase in serum amylase and lipase. In canine pancreatitis, lipase immunoreactivity measured in blood samples 10 minutes after the endoscopic retrograde pancreatography, with these values returning to normal by day 2, similar to the one patient in this study. Another experimental study was performed in clinically normal dogs with aggressive interventions, including pancreatic acinarization, pancreatic duct sphincterotomy, and pancreatic duct stenting in an attempt to induce pancreatitis during endoscopic retrograde pancreatography and not endoscopic retrograde cholangiography. In human patients being treated for benign disease such as pancreatitis-induced extrahepatic biliary duct obstruction or a benign stricture of the common bile duct, a temporary stent would be considered as either single, meaning for pancreatitis, or multiple for strictures, plastic stents, or a covered self-expanding metallic stent, also for stricture, that can be removed in a few months. The reason for removal of the stent is because of the risk of ascending cholangitis. Cholelithiasis is rarely a primary cause. Stone removal in humans during the endoscopic retrograde cholangiopancreatography is one of the more common therapeutic interventions, requiring sphincterotomy, stenting, and lithotripsy, and therefore is the most common cause of complications. Because of the high mortality rates reported for surgical treatment of extrahepatic biliary duct obstruction, which is up to 75%, in veterinary patients, these data support the need for this type of preliminary investigation to find new modalities that can decrease overall morbidity and mortality. The cause for such high morbidity and mortality rates with traditional surgery may be due to systemic disease processes, sepsis, impaired reticuloendothelial function, and surgical risks in such patients. Traditional open surgery may require excessive pancreatic manipulation, prolonged anesthesia in debilitated patients that have a higher risk of dehiscence and abdominal contamination with enterotomies. With endoscopic biliary stents, some of these risks may be averted because of minimal pancreatic manipulation endoscopically, lack of the need for laparotomy and intestinal surgery, and relative speed of the procedure when performed by trained personnel. The biliary stents are considered either temporary, which is typically a plastic polyurethane or covered self-expanding metallic material, or permanent, like a metallic partially covered or uncovered stent. For temporary biliary obstruction relief, such as for patients with obstructive pancreatitis, polyurethane plastic stents are more commonly used and easy to remove after the disease resolves. These stents have been found to maintain patency for 3 to 6 months, which is typically what humans need to resolve the underlying disease. In cases of biliary obstruction secondary to biliary strictures or cancer, permanent metallic stents are often used to avoid the risk of occlusion and stent migration. Benign strictures are commonly reported in human patients associated with chronic pancreatitis, anastomotic lesions after liver transplantation, inflammatory diseases, and biliary stone disease. Bare self-expanding metallic stents are most often used for malignant obstructions or in cases when stent removal is not desired and the risk of migration is high. Covered stents have a polymeric sheath over the mesh, which acts as a physical barrier to prevent tissue ingrowth, like with tumor or stricture, but do not incorporate into the mucosal tissue. These covered stents have a higher migration risk and a higher risk of maintaining and infected biofilm on the surface. Ursodeoxycholic acid is used as a treatment for cholestatic liver disease in humans and vet med. There are many mechanisms of actions of ursodeoxycholic acid, which include protection of injured cholangiocytes against the toxic effects of bile acids, stimulation of biliary secretions, inhibition of hepatocyte apoptosis, and decreased biliary cholesterol saturation. In the case of biliary sediment, this drug is intended to reduce cholesterol absorption in the bile, thereby reducing the cholesterol component in bile sediment or stones, which can result in stone dissolution. Additionally, this medication has been found to increase synthesis of transporters in the canalicular membrane of hepatocytes, which enhances bile flow through making the bile acid composition less hydrophobic and less cytotoxic within the hepatocytes, and possibly decreasing the viscosity of bile. So from this study, they advised that the endoscopic retrograde cholangiopancreography should be reserved for treatment of dogs with extrahepatic biliary duct obstruction secondary to pancreatitis, strictures, tumors, stones, and not for treatment of patients with concurrent biliary mucoceles or pancreatic or hepatic abscesses where surgical debridement or cholecystectomy is needed. Finally, if concurrent hepatic or GI biopsy required, ultrasound or endoscopic guided biopsy can be considered. So that's the study there. Pretty cool. Obviously far from being clinical just because of the training needed and the equipment needed. Obviously, as they mentioned in this paper, you need a larger number of animals, of course, ideally both research and clinically affected dogs, and you want those clinically affected dogs to all have the same disease, ideally. And because these diseases are usually, they're in a small area of the body, as you can see here from the anatomy, everything's so close together, it's hard to get a population of dogs with actual disease that are going to fit the mold for a perfect study. But that's what's needed for these types of procedures. All right, everybody, we'll see you again tomorrow. Take care.